So, thanks again for having me here today. It's very interesting, and maybe someone of you was yesterday at my talk, which had exactly the same title. I'm not Paganini, but I will try not to make the same talk again, although there will be some overlaps. Okay. So these are my conflicts of interest, and I would like to mention that part of the research I will show you has been supported by manufacturers of mechanical ventilators especially. So what do we want to monitor when we have a patient who is undergoing assisted spontaneous breathing? I think we have a series of parameters that we can monitor. So it's 18 of these in the list, and so I have about 50 seconds to talk to you about each one of these. That was a joke, anyway. Okay, so I don't think we will start from a whole list of parameters. You should do this, that, and of course, all of these are very important numbers that we need to take into account where we are managing our patient undergoing assisted ventilation. But I think it's important, and this is a slide perhaps you've seen yesterday, to keep in mind that, as Lorenzo was saying before, when we want to monitor something, the real important point is not which parameter we are going to monitor, but what is the question that we are asking ourselves. So we have to start from the question and look for the monitoring tool that answers this question. Not the other way around, because we have a very fancy monitoring tool, then we start to think how we could use this. And when I try to approach a patient undergoing spontaneous assisted breathing, whether it is pressure support, PAV, partial pressure support, NAVA, BiPAP, whatever, I always try to have in mind the fact that the presence of spontaneous breathing is not good or bad per se. There are some good aspects in the fact that the patient is spontaneous breathing. We can use less sedation, we can use less neuromuscular blocking agents, and has a lower incidence of muscle atrophy. We normally have a good impact on hemodynamics, and we have a better distribution of VQ matching. Yesterday I showed you a slide taken by electrical impedance tomography, where we have shown in a study that indeed the presence of diaphragmatic activity is related to a better distribution of ventilation at the bedside. But we also have to keep in mind that we pay a price to the fact that the patient is spontaneously breathing. There is also a dark side with potential remarkable side effects. We lose control over tidal volume. So the first obvious point is we have to monitor tidal volume and keep in mind that if a patient has ARDS or lung injury, tidal volume should still be in the protective range, even if there is spontaneous breathing. But especially we have the risk of high inspiratory pressure and asynchronies. And just for, as I said, since it's impossible to mention everything, I will try to focus my talk on these aspects, just to show you how this should be monitored in the clinical practice. And to reinforce this sort of good and bad sides of spontaneous breathing, I always show this paper by this very smart colleague, Takeshi Yoshida, now working in Toronto with Brian Kavanagh, where he has induced two levels of lung injury: mild injury on the top half of the slide and severe injury in the bottom half of the slide. And what you see on the right is the effect of letting the animals breathe, allow spontaneous breathing in these animals. And as you see, if the injury is mild and you allow the animal to breathe, this will improve the lung disease. But if the animal has a severe degree of injury and we allow spontaneous breathing, that would even worsen lung injury. And this is why we have written in this report, in this current opinion paper with my mentor Antonio Pesenti, that breathing effort is really a double-edged sword. It has some very beneficial effect, but it can also carry some risky effect. And so we have to have a rough indication of what the effort can be to titrate our ventilatory assistance. As I will show you, we have our standard, our solid ground is esophageal pressure, but we know that this is not that used in clinical practice, so there are alternative tools based on airway pressure or other forms of monitoring, which I will show you. So, how do we monitor the pressure that the patient is generating, the effort that the patient is generating, and how do we have an idea of synchronies? Well, for example, one simple tool, I always speak about this because I think PO.1 is an underestimated or underused but very useful clinical device. It is available in almost every new generation commercial ventilator, simply pushing a button. So I was telling yesterday, if like me you are a lazy person, it's easy because you just have to push a button, or even if you are more lazy you can ask the resident to push it for you. Anyway, so how does PO.1 work? It just closes the ventilator valve for a very short period. The patient does not even realize that, and it's measuring how fast the pressure is dropping. So what is the effort that the patient is putting into the breath? And as you see, the other thing I like about PO.1 is that it can be easily interpreted to the extent that a PO.1 lower than 2 means that our patient is not generating great pressure. A P.1 of 2 and 4 is, I would say, an average effort, and above 4 is a strong effort. Now I might ask you the question, do we think that 12 of pressure support is a high level of pressure support? I won't ask you to raise your hands because it's a stupid question, right? So 12 of pressure support, if you intubate me now, this moment, is a very high pressure support, but you have a patient with weak muscles and ARDS, it's a low level of support. And that's why I like PO.1, because it's a kind of a readout, okay, of how the patient is coping with the level of assistance you're giving him or her. So for example, take these white dots here. These are the patients who are being exposed to a decremental level of pressure support, and they're fine. They can stand our reduction in assistance. See what happens. Their PO.1 is already low at, say, 12 of pressure support. We decrease the level of assistance, which in this case is pressure support, but as I said, could be NAVA, could be the rate of mandatory breaths in SIMV, could be inspiratory pressure in BiPAP, any form of support, but we did it with pressure support. So as I was saying, the empty symbols, winning success patients, they're fine. We can reduce their level of support. Of course, they will increase a bit their effort, but they are fine. The black dots are the patients who will fail the trial. So as soon as I decrease pressure support, their level of PO.1 is going up. And so I have an immediate readout that a patient, for example, on 4 of pressure support, there the black dot, and the pointer does not show up on this very nice LED screen, but anyway, that the level of pressure support for that given patient is low, and the patient is putting a great pressure into the respiratory system. Another thing, once I went to I was invited to one kind of expert consensus panel by a company of producing mechanical ventilators, and a colleague who was there said to these guys in the company, I don't know why you even show waveforms. Numbers is all we care about. Just show peak inspiratory pressure, tidal volume, respiratory rate. The rest is confusing. But I think that if we don't look at waveforms, we miss all the fun, first of all, and a lot of relevant information. Because if we look at this waveform, we immediately recognize, or if not immediately, we can recognize that there are asynchronies going on. And again, on asynchronies we could spend hours talking about, but the message here is looking at the waveform. It's even more important in spontaneously breathing patients than in controlled ventilation, because as you see a bump there where there are the red arrows, those are missed efforts taken from the patient, and the ventilator is not following up. So this is just a glimpse to suggest to you how important is the monitoring, taking a look at the waveform to monitor asynchronies. Because, for example, in this study by Arnaud Thiel, it was shown that if the incidence of asynchronies is high, then the patients will have a worse outcome. Now, this is a little bit of the chicken and the egg question, because I could argue that if the patient has more asynchronies, he or she has a worse lung condition, and that's why outcome is worse, which probably is the case, but still there is a strong association between incidence of asynchronies and outcome. Okay, so esophageal pressure. Esophageal pressure is the standard. This paper was shown this morning in the other room by Salvatore Maggiore, but if you're interested in the topic, I think this is a good starting point. There's a lot of bibliography, so I would recommend you to take this paper. You can download it for free from the Blue Journal. And I think esophageal pressure is important. Again, I've shown this slide yesterday, because pressures during spontaneous breathing are hidden. It's like an iceberg. We see airway pressure, what is outside the water, what is outside the patient. We see the ventilator waveforms, but we do not see the flooded part of the iceberg, what is under the water, inside the patient. And exactly like in an iceberg, this is dangerous because we don't see it, and because it can be much larger than the part that we see. So esophageal pressure is important because it gives us an idea of, not an idea, a measurement, a precise measurement of how much pressure the patient is generating and putting into the respiratory effort. And so the way we measure muscle pressure, PMAS, is the difference between esophageal pressure drop and the theoretical recoil, elastic recoil curve of the chest wall. So it's doable, but at the bedside it can be tricky. Still, it's important to remember that when we have a patient spontaneously breathing, airway pressure tells us little about how much pressure is applied on the respiratory system. Look at this. This is from controlled ventilation to decreasing levels of support. We see airway pressure going down, and we might think, well, things are going well. Airway pressure is decreasing. But if we look at transpulmonary pressure, the pressure that the lung sees, the pressure which affects the lung, there is actually no difference at all, because for the same tidal volume and the same inspiratory flow, transpulmonary pressure will have to be the same. In fact, during spontaneous breathing, we have the generation of a negative pressure outside the lungs. And this is just a remark of what I just showed you. As I say, the transpulmonary pressure is very identical, not very identical, is identical between pressure support of 2 centimeters of water, 12 centimeters of water, and controlled ventilation. But what differs is the way this pressure is applied to the lungs. In controlled ventilation, on the right-hand side of the panel, alveolar pressure is always positive, and has to be like that because there is no negative pressure sucking in. But as soon as you decrease the level of assistance, your alveolar pressure can go down, way below the level of PEEP. And so, in this case, we could have a PEEP set on the ventilator, but our mean alveolar pressure can be barely the same or even lower than the level of PEEP. So just to keep in mind that even if we do not use esophageal pressure, we have to remember that there is a negative pressure going on inside the respiratory system. And finally, in the last 3 minutes of my talk, I would like to show you something about electrical activity, which is a nice alternative to the use of esophageal pressure, I think. This is a patient. This was Saturday afternoon. I was on call in the ICU, hanging around for beds, and around in the beds, and I see this. This was a patient on ECMO, very low compliance. You see tidal volume is about 300 ml despite the high peak inspiratory pressure. And as you see, there is what is being defined the reverse trigger. So not the patient is triggering the ventilator, but as soon as the ventilator starts with inspiratory flow, the patient moves the diaphragm away. This is something that if you look at the 3 classical curves, you would not be able to predict, but it is there. And that's why I think monitoring spontaneous activity of the patient is important. And this is another example. This is a patient going from pressure support to CPAP, to T-tube, to CPAP again. In the bottom line, in the last part of the slide, you see the EDI. You see some change going from pressure support to CPAP, but the large change happens when we remove positive pressure. EDI goes up, indicating that perhaps this patient was not much in the need of ventilatory assistance, but maybe because of cardiac failure, it was positive pressure that really made the difference. And again, it would have been hard to have to see this phenomenon unless we had a monitoring of respiratory activity of the patient. And to finalize this, I would like to show you another aspect, which is the intrinsic PEEP. Especially in COPD patient, this can represent an increased workload and worsen patient ventilator synchrony. You see on esophageal pressure that the patient starts the effort, but the patient has to overcome intrinsic PEEP with the blue mark before the flow can start. Well, we can monitor this also by means of electrical activity of the diaphragm, which mirrors exactly the same phenomenon. We see the activity of the diaphragm going up before the patient can start the flow. And as you see on the right, this is the effect of the application. Sorry, the scale is missing, but what you see on the bottom is the level of PEEP. As soon as we increase extrinsic PEEP, the auto PEEP or the auto EDI decreases. So we can also use these patient ventilator understanding to titrate our external PEEP level. So in conclusion, I think there is an increased knowledge of the potential harm that spontaneous breathing can do to our patient. I think we need to monitor inspiratory effort, whether it be PO.1, whether it be esophageal pressure, EDI, name it, or thickening fraction of the diaphragm. But we need to know what the patient is doing. There are some surrogate measures from the airway pressure, as I said, and perhaps more esophageal pressure or EDI in the future. Thank you very much for your attention.